We have Ms. Radhika Bawa with us. She's the director at Esbee Dynamed, where she leads product innovation and design with a clear focus on building advanced digital solutions for surgical and sterile care environments. She plays a pivotal role in shaping technologies that seamlessly integrate into hospital ecosystems, bridging the gap between clinical needs and intuitive future ready systems. Her approach emphasizes smart, purposeful design that simplifies complexity. Whether it's integrating video, data, and workflows in the operating room or ensuring full traceability in the CSSD processes, Radhika ensures that SB solutions are not just technologically sound, but also practical, scalable, and aligned with the realities of modern healthcare delivery. Ms. Radhika has been instrumental in the development of flagship platforms like Kriya, a comprehensive OR integration system, and Pivot Smart Flow, which digitizes sterile workflows. Her vision continues to drive SB's mission to empower hospitals with connected, intelligent, and efficient digital infrastructures. A very warm welcome to Ms. Radhika. Over to you, ma'am.
Good afternoon, and thank you for that warm welcome. Before I begin, I'd like to understand where all of you are from. So if you can just show me by a show of hands, how many of you are on the hospital side? Building operating rooms, running operating rooms. Okay. How many distributors, partners? Okay. And how many medical students? None? Okay, great. What about IT? Anybody from IT here? All right. Thank you for that. So we are going to explore OR integration. And again, I'd like to understand from you, if you have heard about OR integration, how many of you have heard about OR integration, what it entails? Not heard at all? Heard. Okay. So what is OR integration? All of us know about room automation, right? Where you have one single remote control or one single control panel that can control lighting, air conditioning, maybe curtains going up and down. So there is one centralized system that is controlling many, many functions. Similarly, we see a smartphone in our hands. How many of you remember what our world was like before the smartphone? Do you remember? You had a separate camera, you had a separate calculator, you had a separate email system. Today, all of them are driven from one centralized location. So really, OR integration is that smart system inside your operating room. So why should you care? What's in it for you? Maybe you are a small hospital, just 30 beds. Is this for you? And in all our experience of working in this sector for the last 10 years, I will say a resounding yes. It is for any operating room, whether you are a 30-bed hospital or a 100-bed hospital or even a 500-bed hospital. And it's really, the answer to that will be very evident when you think about how our lives, our day-to-day lives have been transformed by technology. So today, when you want to do shopping, you do it from your phone. You want to pay somebody, you can do it from your phone. You want to have a meeting, you do it from your phone. And that has really changed our business lives, our personal lives. So it doesn't matter if you are a vegetable vendor or somebody running a Fortune 500 company. That technology has transformed your life. Similarly, whether you are a 30-bed hospital or a 200-bed hospital, When your operating room gets digitally connected, it's going to transform your practice. We also hear of shortages, whether surgeons, nursing staff, technicians, trained, skilled people. How do you address this without, of course, medical education and scaling that side of the industry is a solution. But with what you have, how can you make systems work better? How can you do more with the same number of people? That is what digital technologies can address. Remote surgery. We hear of surgeries, robotic surgeries being done remotely from hundreds of miles away from the patient. The surgeon is sitting in one city, the patient is in another city. What is all this? This is technology bringing skill sets to areas that could not have been served without this. So, in summary, we are looking at safer patients. How might you say a patient becomes safer because of surgery, because of OR integration? Think about how they investigate air crashes. How do you know what has gone wrong? If you are recording your surgeries, if you're documenting your surgeries, there is a way to go back and see what has happened, what has gone wrong, what could be better done the next time. The same way, the same principle applies to patients and patient care. If you don't have a system that allows you to go back and review what could be done better, how can patients be safer? Learning. There was a time when you had an operation theater and a surgeon or professor standing and operating, and 20, 25 students gathering inside the OR, looking over the surgeon's shoulder just to watch that surgery being done. But today, with infection, with stringent regulation, that is no longer possible. So how do you train students? How do you train practitioners on complex surgeries? And of course, being future ready. Robotic surgery is here to stay. How can robotics be integrated into the overall workflow of the hospital? The answer is OR integration. The core philosophy behind integration is number one, communicate better. Because surgery is a collaborative effort. There are many teams that are coming together. It's not just people inside the operating room, but also people outside the operating room that are supporting this surgery who need to understand. The head nurse needs to understand how my cases are scheduled. The person who is scheduling staff needs to understand whether there is overbooking inside, whether the devices are available on time. Surgeons need to understand how their day should be planned. Right? So there are so many different needs that different teams have. You can care better because you now have the history of this patient inside the operating room. You're no longer looking at paper or you're no longer guessing. You have all the patient records at your fingertips before you operate on the patient. And you utilize better, just like we said. Your staff, your technicians, your surgeon's time, all of that can be better utilized. So if we look at the evolution of integration systems, it actually, clearly the journey can be mapped with the transition of medical technologies. Earlier you had open surgeries. When minimally invasive surgeries came, the importance of images and being able to view them clearly while operating brought the need for AV management, audio-visual management, right? Then you wanted to collaborate, you wanted to review, you wanted to teach. So collaboration, recording, the teams needed to see, the anesthetist needs to see what's happening on the surgical side. The surgeon needs to see how the patient vitals are doing. So inside the surgery, inside the operating room also, there was a need felt for large monitors, multiple monitors, and monitors that could display different sources at different times. Then came the need for training students remotely. And the advent of telemedicine, the advent of use of video conferencing and streaming in medical education. With robotics, that becomes one more stage up, because now you have a surgeon who's not at the patient's side. So how do you bring the surgeon who is remote and the team that's at the bedside on the same platform? Again, you need collaboration. Now, more and more, as hospitals digitize, the workflow has also become important. So, what elements of workflow? Number one, how are your surgeries scheduled? What are the different times at which patients need to be wheeled in? Are we doing surgeries on time? How is the utilization of your operating room? Do you have lean periods? Do you have busy periods? Are you using your rooms efficiently? Then, post-surgery, how are you creating your surgical notes? How are you archiving all the information for the patient? Are all these things happening in different systems, or are they all talking to each other so that the patient's experience and the surgeon's experience is seamless? And last but not the least, today we have AI as the buzzword coming up. So in the future, could we think about AI bringing in decision support or smart assistants or risk assessment for a patient? This is how OR integration is also changing, just like how surgical technologies are. So, what is OR integration? What is involved? There are 4 basic elements. The first is, of course, video and imaging. Then there are patient records, which is your HIS systems or your PACS systems. You have patient monitoring, live feeds, and then you have the hospital workflow, which is your HIS, scheduling, inventory management, billing, all of those, right? So when all these come together, that is what we mean by OR integration. Inside the integration system, the main part of the integration system, or the brain, is the central control box, right? That is what is bringing all the rest of the technologies together. Then you have AV technologies, monitors, cameras, AV components, control systems. You have digital connections, basically cables. How are you going to route all these how are you going to connect all these AV systems together? And last but not the least, software. So we'll see some of these in little more detail. What's inside the control box? Number one, video processing. You have so many different cameras now present inside the operating room. You have an endoscope, you have a C-arm, you have the surgical light camera. Most operation theaters now have a PTZ camera. So all those camera feeds, today we see that there are recorders, but then you have to take a pen drive to remove the recording, and once that pen drive comes out of the operating room, how do you control that recording? Where does it all come together? So that is the central part of audio and video management. The second is the compute power. So you take all that recording, it needs to be stored somewhere. What should be the capacity of that storage? You need to share it. So what kind of sharing mechanisms should you have? And the third, integration. So this system also needs to talk to your HIS system. From the HIS system, you want the OT schedule for the day. You want to push patient record back into the HIS system, or you want to put billing information back as to what has been consumed inside the operating room. So these kind of integrations can be done through the API layer or the integration layer. So these 3 components constitute what we call the central control unit. Coming to the digital connections. How many of you have heard of AV over IP? Do you know what AV over IP is? audio visual over internet protocol? Yes? All of us have experienced it in a way. Could you give me an example? Where have you experienced this? CCTV cameras? Yes? What else? Yes? Right? So today, video is being served to your mobile phones using some of these technologies. Right? These are all packet data. Just like how email is coming to you, video is also coming to you through packet data over the internet, over internet protocol. So when we are talking about integrating different devices, you can either use the traditional audio-visual technologies with HDMI cables, DVI cables, SDI cables, or you can use AV over IP. What is the difference? You can see here, this is the AV source, that means the camera. Think of this as your endoscope or a C-arm, whatever medical camera you have. You have, if the distances are long, you might have a transmitter connected to your camera. Or you could just do away with this transmitter and straight away send this camera to a switch. That just like how we change channels on our TV, if you have multiple cameras connected inside your operating room, then you might have something like an AV switch. And then you have a monitor that is connected to this AV switch. So in traditional AV, you are talking about connecting the camera to a destination such as a monitor or a video conferencing system through a switch. In AV over IP, there are some more layers. So at the heart of this is the network switch. The same type of switch that handles your LAN, right? Data network. Just that this switch is meant for video data instead of non-video data. So you again have your camera and you have your monitor. In the middle, what you're doing is converting video signal into packet signal, IP signal. So there is an encoder that is changing an HDMI into packets, and then it's coming to a decoder, which is changing the packets back into HDMI, and then showing that feed to your monitor. So in both the cases, the function is the same, matching a source to a destination, but the technologies that are used are different. One is using traditional AV, one is using AV over IP. So which one is better? The answer is it depends. It depends upon how complex your operation theater is, how many cameras do you have, what resolutions. Everybody understands resolution? Yes? Maybe a nod of the head will be good. We have heard about 4K, full HD, those are resolutions, right? So if you have a 4K laparoscope, you obviously want your AV system to handle 4K signal, correct? So then, where do you want to send this signal? Do you want to send it within the operating room? Or do you want to send it to a doctor's lounge? Or do you want to send it to a classroom for students to view? What is the user case that you want to deliver? And that's what will determine whether you would take the AV route or the AV over IP route. Both technologies are, shall we say, state of the art. There is all of us use 4K televisions inside our homes, offices, right? That is your traditional AV. And both technologies have their place. So, how do you choose? These would be some of the considerations. Budget, of course, right? The minute you say AV over IP, you are thinking about encoders, decoders, and increasing the budget that is required. Complexity. If you just have one camera and one monitor inside the operation theater, you know what the answer is. You don't need a complex system. But the minute you say, I have 4 cameras, I have 4 monitors, I want to send the stream outside to a classroom, I have a doctor's lounge where doctors need to see it, I have a nursing station where I need to see a live feed, that is where things start getting complicated, and then maybe AV over IP becomes a better choice. Flexibility. All of us know how easy it is to extend LAN networks, right? Suppose in an office you have 5 PCs. It's pretty easy to add a 6th PC. You have a switch, you have a port, you just add a PC. It's not the same when you say that I have an AV switcher, and now instead of 5 cameras, I want a 6th camera also. Then that is where things start getting trickier. In this sense, AV over IP is like extending your LAN network. You can probably just get another switch and interlink those switches. So flexibility, future expansion, upgrades, AV over IP. But if you see in a traditional sense, the OT environment doesn't change every 5 years. Typically, when you build an OT, you know what you're building for, and for the next 7, 8, 9 years, you are pretty much set. So I would say AV over IP, yes, but so also traditional AV. It all depends on the big B. What are the other considerations? How far are the routing distances? Suppose you have 2 buildings. The OT complex is in one building, the auditorium is another building, classrooms are in a 3rd building. Then AV over IP, because that range extension is not going to be possible with traditional AV. Specific display resolutions. You have some monitors that are 4K, some that are 3D, some that are full HD. Again, AV over IP. And any unique cases. Specific requirements of a hospital or an operation theater. All these considerations need to be kept in mind when designing the system and choosing the technology. I will skip this because not too many of you knew about AV over IP, but just 2 points. If you ever get to a situation where you are evaluating AV over IP, remember this, AV over IP is not recommended to be run over your existing network. If you have designed a network for data traffic, don't run video over it, because the nature of data and video are very different. In the case of data, if an email arrives maybe 1 hour late, it's okay. But in the case of video, you can't have a video arriving 1 hour late, right? You want the video to run at the speed at which it is supposed to run. Similarly, not all AV over IP is the same. There are various protocols, there are different use cases, like YouTube is a use case. It uses a different protocol, correct? You have production or broadcasting that uses a different protocol. So it depends really on what the need is. Inside the operating room, you can't use the same technologies as YouTube. Why? Because the YouTube resolution that you get is not going to give you the clarity that a surgeon expects out of the feed, right? So what I'm trying to tell you is, understand that there are different protocols and you choose based on what your need is. I have covered this. One point I wanted to make also is archival. A lot of hospitals that we meet think a lot about how many cameras, how many monitors, what recording, what streaming, what video conferencing. But this area is largely ignored, and that area is archival. What do we mean by archival? When you store video, let's say you do a surgery for 1 hour, and if you have full HD cameras, that surgery is going to take 2 GB space, 2 gigabytes. Now, if that operation theater is doing 4 surgeries a day, that's 8 gigabytes. Now that's theater, that is 1 day's data. Multiply that by the number of months and multiply the number of years, and you very soon have a storage problem. If your hospital wants to store medical data for, let's say, 5 years, 7 years, how are you going to plan the storage of this data? How are you going to make sure that when a surgeon needs to refer to this case, maybe there's a readmission case after 2 years for a cancer patient. Now, how are you going to access this? Are you going to look for it on some pen drive or on some portable drive, or are you going to have a system of archival that allows you to do this very simply? So pay attention to this as well. Streaming versus conferencing. Is the difference clear? Streaming, we all watch video on YouTube. That's streaming. And conferencing, Zoom, Teams, Meet, that's conferencing. So when you have collaboration requirements, what is your requirement? Is it a classroom session where the student needs to be able to talk back to a surgeon? Is it an expert guidance where 2 surgeons need to talk about a case? Or is it the case that somebody from the operation theater is just relaying this information and somebody is just watching it maybe to know where the case is at? All three require different approaches. So streaming is good when interactivity is not required. Video conferencing, of course, offers you bidirectional interactivity. The next one, medical protocols. All of us know that there are standards for data privacy that are coming up. So HIPAA compliance, encryption, patient data security, these are very, very important. Consent, patient consent, these are all important factors that you must consider when selecting a system. I spoke about this, what are the interaction needs, and what are the audience dynamics? How many people need to view the surgery? Is it a large distributed audience, maybe thousands of people joining for a CME, or is it a one-to-one collaboration, or there are just maybe 3-4 people joining on a call? All these need to be kept in mind while deciding what kind of sharing and collaboration can be offered. Last but not the least, software. You can have the best hardware, the best monitors, the best cameras, but if the software is not great or it's not user-friendly, then adoption of the system is going to be a problem. Usability for the healthcare user is the most critical element. Our healthcare users are not AV experts. They don't understand resolutions, they don't understand signal type, they don't understand what is DVI, what is HDMI, what is SDI, they don't understand that. They need a system that's easy to set up, easy to use, fast to boot, fast to shut, right? So usability is very, very important. Is the system designed for clinicians or is it designed for AV technicians? That is also a very, very key factor. What is good for an auditorium or a seminar hall is not good for the operating room. The operating room has other considerations. You want something that is very simple. You don't have to sort of think about, okay, how is this system going to work? How am I going to start it? How am I going to connect it? Single platform delivery. We don't want 5 remotes operating, 1 remote operating a camera, 1 remote operating a monitor, 1 remote operating the recording system. It should all happen via one centralized control. And software really is a must-have. It's not a nice-to-have. It's not an afterthought. That should be the key way in which to evaluate a system. So what all is possible? The entire patient journey, surgical patient journey, can be mapped on through OR integration. So beginning from pre-surgery, patient admission and scheduling, Diagnostics review. Do you want to pull up a case from PACS? Do you want to pull up a case from your RIS system? Do you want to see case files of this patient? Do you want to see allergy data? Do you want to see his past medical history? And preparation of the theater according to the surgeon's requirement. Intraoperative, during surgery, you want to verify that you have the right patient, right surgery, the WHO safety checklist. You want to access the surgical plan. Maybe you have made some notes outside the operating room. You want to bring them inside. You want live imaging to see what's happening, your patient data, your endoscope feed, your laparoscope feed, your microscope feed, and tool integration. Real-time collaboration. If you want expert opinion, expert guidance, you want to consult somebody, all of these during surgery use cases can be delivered through our integration. And lastly, post-operative. Monitoring the patient after he leaves, preparing notes for data archival and for patient history, patient reporting, as well as billing. So what have you consumed inside the OR? All those billing records can also be pushed via workflow integration. So I come to the last part. How do you approach a project like this? And like all projects, it should all begin with the goal in mind. What do you want to achieve inside your OR? Are you simply looking to document, or are you wanting to share, collaborate, integrate? What are your goals for your operation theater? There are many stakeholders in an operation theater, and as far as possible, we need to take inputs from all. The surgeon is, of course, a key, but so is the technician, so is the nurse, so are planners, so are administrators. Technical needs. What sort of cameras do you have? What sort of technologies? What are your existing infrastructure challenges? Suppose an OT is already built. Now you want to add OR integration. How can you do it? Do you have the possibility of opening up the OT or shutting it down to add this technology? Or do you want something that can be mobile and just wheeled into the theater? And of course, after all of these, select the right partners. It requires careful thought, planning of all aspects. The key questions to ask: is this a new OT, or is it an existing OT in which the system needs to go? Because the approaches, the answers will be different. What needs to be connected? How many? Where? What needs to be? Who needs to talk to whom? Sharing. Who needs access? Do we need access for a surgeon, a technician, a nurse, a visiting faculty, a classroom, a student? Who needs access? What are the integration points? Which other systems should this system talk to? And how will you store, retain, and access this data after the surgery is done? So you must have understood that this is a long-term project. It is almost like implementing a hospital information system. It's not a short-term, it's not a one-off. So you need a partner and not a vendor. You need long-term relationships, you need local support, you need possibility to integrate with your flows. You need flexibility in software. And user training, very, very critical. Every person who is going to touch this system needs to be trained. Otherwise, like many systems inside the hospitals, it will not get used. And then the technology gets the bad name, right? That it's not necessary. The problem is the users are not trained. Avoiding pitfalls. In so many discussions we have with customers, this is the number one pitfall. Somebody has come and sold us something, now we want to get it, but at fraction of the cost. That doesn't work. And not all technologies are for all operating rooms. So it is very important to have that discussion about what your hospital requires and focus on needs, not on trends. Include all stakeholders, I've already covered this, and consider the total cost. The cost is not just the system, it is the archival, it is the infrastructure, it is the training, it is the customization, all of that. It is also good to take a modular approach. So don't go with all bells and whistles day one. Build slowly, build piece by piece, build modularly. Those are the approaches that have worked in the past, and it will also help you understand what your hospital can absorb, what your users can absorb. That's it. Thank you so much.